Today's educational objectives for hepatitis B are, we're going to talk about the areas that are endemic for hepatitis B in the world, low prevalence, intermediate prevalence, and high prevalence. And we're going to talk mainly about how to address culture-specific barriers with the patients and also clinician barriers. You know, we work in a high-stress environment, so there are several barriers, and we'll talk how we can overcome each of them. So just to begin with, knowing about hepatitis B, of all the viral hepatitis, hepatitis A, hepatitis B, there are up to, hepatitis C, hepatitis delta, hepatitis E, and hepatitis G. Okay, so there are about 5 different viral hepatitis. Out of all of these, hepatitis B is one of the most commonest. There are at least 2 billion people in the world who are infected with hepatitis B at some point. Now, if you look at the number of chronic carriers of hepatitis B, it's about a whopping 257 million individuals. If you look at US is not endemic for hepatitis B. We actually, out of the 257 million, we actually have less than 1 million individuals with hepatitis B. And again, a lot of it is still an estimate. We actually think that due to the number of immigrants, due to the number of individuals with chronic hepatitis B who remain asymptomatic, a real number could be as high as 2.2 million. And again, the important thing is hepatitis B, because it is a chronic disease, it leads to cirrhosis and hepatocellular cancer. This is primary liver cancer worldwide. Now, one of the things that I kind of want to use as a theme throughout this session is contrast between the other virus, which is hepatitis C. Okay, so hepatitis C or other causes of liver disease like alcohol, fatty liver, typically they cause liver cancer only after you develop cirrhosis. However, in hepatitis B, 30 to 50% of liver cancers are found without the presence of cirrhosis. Okay, very important distinction. So remember, hepatitis B is a carcinogenic virus and it does cause cancer. And because of its carcinogenicity, it's only second to tobacco in causing most cancer-related deaths. And if you all remember from the old textbook, medical textbooks, that hepatitis B is actually more infectious than HIV or hepatitis C. Okay, a small drop of blood is more of an infective inoculum than the rest of the viruses. So again, if you look at the worldwide distribution of hepatitis B, you can see that Africa, Asia Pacific, including Australia and China, they actually have the major brunt of hepatitis B. Rest of the world, including India, some other parts of Middle East, Northern Africa, and South America, they are next in the line. North America and parts of Europe, they actually have low prevalence of hepatitis B. So 68% of hepatitis B is seen in Africa and Western Pacific. Okay, and again, about 2.7 million individuals also carry HIV along with hepatitis B. Remember that hepatitis B vaccination is preventive, and most of the infected persons who are born before the universal vaccination protocol do have hepatitis B even during their infancy. So again, this is to show a worldwide distribution. To keep it all simple, high endemicity is described as more than 8%. So again, remember the areas which are in green. This is parts of South America, Africa, and Asia Pacific. Again, other than North America and most of the developed parts of Europe, a lot of them are considered as intermediate to high prevalence. So why are we talking about hepatitis B in US? Well, out of the 850,000 patients who have hepatitis B, a lot of these patients, a lot of the hepatitis B is actually seen in the immigrant population. So again, you can see that this is demographic data collected between 2010 and 2017. that the immigration numbers from all the endemic areas of the world are the reasons why we do see hepatitis B in US. So if you look at the top countries of foreign-born individuals who have hepatitis B, so China, Vietnam, Philippines, DR, Mexico, and again, where I practice, Haiti. These are some of the countries where you actually see a lot of, these are the populations with high prevalence of hepatitis B. And if you look at foreign-born individuals by region, Africa, Asia are the top, Oceania, Caribbean, and all the others, other regions of the world form this matter of hepatitis B. So again, to kind of reiterate the point, hepatitis B typically is seen in foreign-born individuals, typically those countries that have intermediate to high endemicity rates. And again, when you look at the trends of immigration, you can see that China, India, Haiti, these are some of the endemic areas of hepatitis B, and those are the areas from which most of the immigrants to US hail from. So one of the audience members was talking about we need to eradicate hepatitis B. I like the energy that she had. And really that's the goal by the World Health Organization. So the goal is to eradicate both hepatitis B and hepatitis C by 2030, okay? So in order to achieve that, if you follow the graph from below, vaccination coverage should be at least 90%. Now, we do a very great job in US. We do vaccinate a lot of susceptible individuals. We're about 84% with vaccine coverage. So again, I think by 2030, we can increase by another 6% in order to achieve that goal. Blood safety. So this is screening for hepatitis B in all the blood donors. And we do a really great job in screening the blood and blood products for hepatitis B. We are at 97%, and really 100% is the goal set by the WHO. Where we lack is really the diagnosis of hepatitis B, and of the people who are diagnosed with hepatitis B, linking them to treatment and care. So we are in 2019, almost in 2020, but we are still about 10% in diagnosing and linking the individuals to care. So this is where we need to do a good job in increasing that number to almost 80 and 90% in order to achieve the WHO goals. So when we talk about hepatitis B modes of transmission, as I said, why are endemic countries of the world, why do they have high prevalence of hepatitis B? Well, most of the hepatitis B infection happens vertically. The transmission is from mother to baby at the time of the birth. Horizontal transmission, this is again when the child is in early infancy and childhood. The virus can get transmitted from close contacts in the house, and the virus can survive approximately a week outside the body. So it can reside on fomites, it can reside on razors, it can reside on several household material through which a child can actually easily get infected. Healthcare, again, there is use of non-sterilized needles, contaminated needles, reusing of the needles and syringes, and these are some of the reasons why there's also healthcare-related hepatitis B transmission. And again, parts of the world that we're talking, which are endemic, also have other traditional medicine like acupuncture, coining, cupping, scarification, all of these which basically increase that risk of transmission of hepatitis B. In non-endemic countries, this is prevalence rates less than 2%. So typically Europe, North America, USA, Canada, and parts of South America, it's mainly due to horizontal transmission, adult sexual activity. It can transmit via heterosexual contact and also homosexual contact. And again, the most commonly through IV drug use. This is a virus that gets transmitted parenterally. This doesn't get transmitted via contamination of food or water. This gets transmitted via blood or body fluids. Okay. So some of the myths about hepatitis B transmission is, again, like I said, it is not transmitted through casual contact. Okay, so where there is no transmission, where there is no exchange of body fluids or blood, you're not going to have hepatitis B transmission. So hugging, shaking hands, kissing, sneezing, coughing, even breastfeeding has shown not to increase the risk of transmission. Sharing utensils, drinking glasses, air, food, or water, again, these are not the way hepatitis B is transmitted. It is transmitted through exchange of blood and body fluids. So again, like I was saying, the theme will be to kind of contrast between hepatitis C and hepatitis B. So hepatitis C is a cytoplasmic virus. It resides in the cytoplasm. And again, hepatitis C is not a very contagious virus, but hepatitis B is highly contagious, and hepatitis B incorporates itself, it puts its cccDNA in the nucleus of the host cell, and therefore there is no curative therapy. So once it gets into the liver, it typically resides until you achieve a seroconversion or until you achieve a cure, which is not very frequent. Does anyone have questions thus far? I just want to take a brief pause. If no questions, okay. Again, please feel free to use the chat box or unmute yourself and ask questions. Okay, this format is supposed to be highly interactive. The more questions you ask, the better it is. Again, we're all going to be learning from each other. Okay, so moving on. If you look at the hepatitis B life cycle or the natural history of hepatitis B, one of the major things we need to remember, this is the take-home slide if you want to remember one slide out of the whole, is the transmission rates are higher when the child is born or immediately after birth. Okay, so if the child gets exposed or gets the hepatitis B transmission at birth or in immediate childbirth, 90% of the individuals will develop chronic hepatitis B. Whereas as the child becomes older and into the teenage and adult years, if that individual gets hepatitis B exposure after, these patients can clear the virus because they all have a competent immune system, and chronicity rates are less than 10%. Okay, so again, very important, 90% of them become chronic if you get hepatitis B at childbirth, whereas 90% will clear the virus if you get hepatitis B after age 5. So again, this is the same illustration of the previous slide. More than 90% will get chronic hepatitis B. They do remain in a phase called immunotolerance phase, whereas if you get it as an adult, most of them will clear the virus. But again, if you don't clear the virus, you do have an inactive carrier state, or you do have a chronic active hepatitis B, and that is a risk for liver cancer. That is a risk for cirrhosis and advanced fibrosis. So this is kind of a rhetorical question, who should be screened? Again, in general, almost all patients should be screened. There is a universal vaccination protocol after 1995 where every newborn should get hepatitis B vaccination. But again, what is written in most of the US Preventive Task Force guidelines is, if you're a person from intermediate or from highly endemic areas of the world, you should get screened. If you are a child of parents born in highly endemic areas of the world, you should get screened. Household and sexual contacts of hepatitis B carriers should get screened. injection drug users, multiple sexual partners, history of sexually transmitted infections. Again, all of this highlights the parental transmission of hepatitis B, so again, they should be screened. Men who have sex with men, inmates of correctional facilities. Again, as part of chronic liver disease workup, if you see a patient with elevated liver enzymes, this is one of the screening tests you would perform. Individuals with HIV or hepatitis C, dialysis patients, immunosuppressed patients, pregnant women, and infants born to carrier mothers. All of this, there is a high-grade evidence to get screened for hepatitis B. So again, to reiterate the point we talked before, this is the areas of the world that have the intermediate. More than 2% is intermediate, and the red regions are the ones with high prevalence. Okay, so remember that most of the world is either blue or red, except for America, some parts of South America, Australia, and Europe. So what are the potential consequences of hepatitis B? We know that untreated hepatitis B can result in liver cancer, and this is the cause of 60 to 80% of liver cancer worldwide. It is a class 1 carcinogen, and it's only second to tobacco for causing cancer-related deaths. Untreated hepatitis B would also cause cirrhosis. This is excess fibrosis and cirrhosis in a patient with untreated hepatitis B. So this is again to show the natural history of hepatitis B progression. Once the individual gets an acute infection, especially if it's a kid, most of those patients will get chronic hepatitis B, of which 5 to 10% will eventually develop liver cancer throughout their lifetime. About 30 to 40% will develop cirrhosis. And again, a lot of patients who develop cirrhosis can also develop liver cancer or develop decompensated liver disease. Now, when you look at the liver transplants done for hepatitis B, since the vaccination has been in use, the numbers of hepatitis B as an indication for transplant has been declining. However, it's the 6th leading cause of liver transplantation in the United States. Most of them actually develop liver cancer rather than cirrhosis. So of the several hepatitis B parameters, what is the one parameter that is associated with worse outcomes? So this was a very unique landmark study that was published in JAMA in 2006. Now, this high numbers of patients with hepatitis B cannot be replicated in the US. So in this, about 3,500 patients were followed up for almost 13 years. And they were followed up with liver enzymes, they were followed up with hepatitis B E antigen, E antibody, you name it. So several different parameters. What this study has shown, which has answered a lot of the questions, is if you have a viral load more than 5 logs, so this is 100,000 or above, that alone puts you at risk to develop cirrhosis, okay? So for all the parameters, not even liver function tests, not even hepatitis B serology status, the presence of DNA more than 5 logs is associated with worse outcomes. So that is with cirrhosis. And again, it also holds the same, it also holds true for HCC, okay? More than 5 logs, the incidence of HCC really goes up from a 3% to almost 12%. That's almost 4 times higher. So another thing to remember is hepatitis B can remain silent. Okay, most of the patients who have hepatitis B are actually young adults who do not have any major symptoms. So unless you actually screen them and you actually ask questions about where they were born and get a good history, it is unlikely that you're going to pick up chronic hepatitis B just by conversation. And again, you may think that most of the patients with hepatitis B will have elevated liver enzymes. not true. Most of the patients in the immunotolerant phase, especially those from the endemic areas of the world, can have completely normal LFTs, okay? So this is called the immunotolerant phase. So unless you check for hepatitis B surface antigen, you're not actually screening them for hepatitis B. And therefore, again, as many as 2 out of the 3 chronically infected patients are unaware of hepatitis B. So again, this is where we have to do a good job in diagnosing all the patients who are infected with hepatitis B. Remember the first slide where I said there is an estimate of 850 million chronic hepatitis B carriers. However, the real diagnosis is probably in 2.2 million. Okay, so we need to increase that number in order to capture all the patients who are infected. So now going to the second part of our talk, which is understanding barriers. So first, let's talk about the patient barriers. So patient barriers, again, when you are busy in your clinic and you see patients and you basically want to pick up a topic like hepatitis B and you talk to them about screening, again, there is a lot of barriers like lack of understanding, like why should that individual be screened for hepatitis B? I see this very often in my clinic. This is especially from the population from Haiti. And again, this is also common in other cultures, not to stereotype any specific culture, but cultural beliefs and shame. So someone who has a parenterally transmitted disease, some hepatitis itself, the word hepatitis is linked to like a bad stigma. So they stigmatize themselves having something that is shameful. They stigmatize themselves having something that they shouldn't have, and they don't talk about it. And then there are issues about privacy, and therefore we really, really need to find a context. Like we should talk to the patient and listen to them and find a way how we can basically piece in the screening for hepatitis B during the interview. Again, we should talk to them about the value of testing. We should emphasize that most of them can remain asymptomatic. And then again, you know, in this day and age, financial barriers are definitely one of the challenges. Even if you identify a patient with hepatitis B, how do you plug them to your clinic? How do you counsel them for treatment? So all of these will become very crucial in real world practice. Language barrier, I don't think it is much of a barrier in most of us who are working in urban centers, but again, in certain parts of the US, it could be a barrier. So again, when we talk about solutions for patient barriers, again, no insurance definitely is what I think is a barrier in my clinic. So again, local community centers and public health departments, they provide free hepatitis B screening. We actually have a lot of outreach programs in our own university, and we go out almost on a quarterly basis and screen patients for all 3, actually, hepatitis B, hepatitis C, and HIV. And once we've identified individuals with positive hepatitis B, we link them to care. And then again, the most important aspect of doing the screening is also to provide education, okay? So the person who might be coming for the outreach, the person who might be screening may be negative, but again, their household members, their family and friends could have hepatitis B. Again, if you educate the patient, if you educate the individual, they will actually circulate it and talk to other members that they know about hepatitis B. So again, we need to engage the patients. That's really the crux of all this talk. We need to provide a context why hepatitis B screening is important. So we need to take a good family history. We need to identify the risk factors, understand the demographics. And we need to discuss the risks of co-infection as well, not just for hepatitis B, but for other parenterally transmitted illnesses. And again, at the same time, a lot of the patients who have hepatitis B may also have other concomitant risk factors: alcohol use, smoking, uh, substance abuse, and again, sexual history. So all of these could be high risk variables that you need to counsel the patients about. So once they have hepatitis B, we need to destigmatize them that hepatitis B is a vertically transmitted infection. And again, hepatitis B is a cancer-causing virus. So early screening and really involving them in care is really the way to go. Okay. So again, we need to highlight how it is transmitted. We need to emphasize that, again, if they're susceptible, it's easy. You can vaccinate the individuals who are susceptible to hepatitis B, and you can prevent them from getting hepatitis B. Okay. Clinician barriers, again, I don't need to preach the choir. We all work in this high stress environment, too many things to keep track of. We need to accomplish a lot of things in a short time, RVUs, too many things that play into our regular clinic visit. Hepatitis B serologies, again, from a clinician standpoint, this is what I see as a barrier, even in my own GI trainees and internal medicine trainees. The serologies are confusing. And then you look at hepatitis B guidelines. How do you manage? How do you treat? Different societies. Asia Pacific Society has different guidelines. American Association has different guidelines. European Association has different guidelines. So again, it depends on which guidelines you're following, and those guidelines can be confusing. And most of the time in the electronic health records, there are no reminders. So we see, sometimes part of the hepatitis B panel is done. It could be a surface antibody that is done, and that's about it. So we don't know if the patient has surface antigen or core antibody. Was the patient previously infected? So in order to counteract, again, I think electronic health records also need to play in and make our jobs a little bit easier. So solutions that we propose are, we need to talk about risk assessment. So really understanding the patient, where he comes from, and putting those risk variables. We need to understand hepatitis B screening guidelines. Now, it's not that easy as said, and which is again why ECHO project is important, that the more you listen, the more you understand, the more you'll be confident in treating patients with hepatitis B. We need to find effective ways to engage the patients and effectively screen and also interpret the serologies. We need to find an opportunity that if a patient is positive, we need to either treat. If we can't treat, we can refer them to a particular specialist for hepatitis B. And if they're susceptible, vaccinate them. So that way, again, you will reach that WHO goal of eradicating hepatitis B by 2030. Okay. And again, we also will talk about how to identify social services like insurance, immigration, and other aspects, and when is referral to a hepatologist or a transplant center appropriate. So system solutions, again, there is no one glove fits all. You need to work with your own group, identify what your strengths and weaknesses are, and come up with an appropriate plan for your own system. Again, we can talk about all these if at any time during the next 5 modules or today, and we can talk how we can find an appropriate opportunity. So again, when we're talking about patients, some of the patients can say, you know what, I already got hepatitis B vaccination, I'm not at risk. Okay. Remember that if a patient actually had hepatitis B transmission already, no matter if the patient gets vaccination, that person is still chronically infected. Okay. So we need to keep in mind that especially persons born in areas which are intermediate to highly prevalent areas, they should be screened for hepatitis B. US-born persons who are not vaccinated as infants, but their parents come from a highly endemic area of the world, they should be screened. Again, don't deter screening for hepatitis B, even if they say they received a vaccination. Again, it's a one-time test. Do hepatitis B core antibody, surface antibody, and that should be on their chart forever. Okay. So Rachel, can we go to case 1?
Yep, I'm gonna share my screen and play that video with you all.
Sure.
Yu Wen Lee is a 28-year-old woman who presents for a family planning visit. Yu Wen was born in the United States to parents who immigrated to the U.S. from Taiwan 30 years ago. She has no significant medical history. Hello, Miss Lee. I understand you're interested in becoming pregnant.
Yes, my husband and I have been talking about it for a while, and we think it's time. My parents will be so excited.
Have you told them yet?
Not yet, no. I wanted to talk to you first. I wanted to know what to expect before we started telling people.
Okay, well, this is a good place to start. There are a few tests we can consider, and we'll talk about your lifestyle habits and your health history.
Okay.
I see in your records that you received most of the recommended vaccines, and you were born in the U.S.?
Yes, my parents are from Taiwan, but they came to the U.S. before I was born.
Any family history of illness?
I don't think so. My dad takes medication for cholesterol, but he and mom are fine, and I'm my only child. I did have an aunt who died a couple years ago in Taiwan. They said it was liver cancer, but I didn't know her very well.
Okay, let me ask, have you ever heard of hepatitis B?
I've heard of hepatitis.
Well, hepatitis B is a virus. It can cause liver disease and liver cancer if it's not treated. The reason I ask is that hepatitis B is common in certain regions of the world. Taiwan is one of those areas.
Do you think that's what my aunt had?
Well, it's possible, but I couldn't say for sure. But we should definitely screen you for hepatitis B since your parents were born in Taiwan. National guidelines recommend a one-time screening of people born in countries with a high amount of hepatitis B, and that extends to children born in the U.S. to parents from those countries.
Oh, really? How is it transmitted? Can it harm my baby?
It can be transmitted through body fluids like blood or semen. For example, it can be transmitted through sexual contacts or injection drug use, and it can also be transmitted from mother to child during pregnancy or birth.
No, my mom and dad met in high school. There's no way they got a sexually transmitted disease. And I married my first serious boyfriend. No one in my family has ever used drugs. This can't apply to us.
Okay, let's just go ahead with the rest of the exam for now. Okay.
Okay, Ram, I'm going to turn things back to you before we play the second video.
Okay. So anyone in the audience, you want to kind of talk about, do you see that this kind of story is real in your practices? Anyone want to voice your opinion? Okay. So, I mean, clearly the patient has told us that she's from Taiwan. She's from the areas that have a very high prevalence of hepatitis B, more than 8%. Okay. And this is a unique opportunity. She's wanting to get pregnant. And even though she's born in the US, she is, according to the guidelines, needs a hepatitis B screening. So let's see that how we can use this opportunity. So instead of, patients who are stigmatized, this is a classic scenario where they have the cultural barriers. Okay, so let's use this opportunity and see how this interview should have been done and how we can destigmatize the patient's perception of hepatitis B. Rachel, take away.
Let's just go ahead with the rest of the exam for now.
Do you think that's what my aunt had?
All I would say is that your aunt's history raises my level of concern. I recommend testing you for hepatitis B because your parents are from Taiwan and also because you're considering becoming pregnant. The Centers for Disease Control and Prevention recommend a one-time screening of people born in countries with a high amount of hepatitis B, like Taiwan, and that extends to children born in the U.S. to parents from those countries, like yourself. It's especially important for you because one of the main ways hepatitis B is transmitted is from mother to child during pregnancy or birth.
You mean I could have gotten it from my mom without knowing it, and I could pass it on to my baby?
That's correct. Outside the U.S., mother-to-child transmission is the main route of transmission for hepatitis B.
But none of us are sick. I mean, my aunt died. Shouldn't we be sick?
People who have hepatitis B can seem fine for many years before they start to show symptoms. It's often silent. We want to treat anyone who's infected before they get sick, and also to prevent them from giving it to someone else.
I get it. I guess that's okay.
If the test comes back positive, which is unlikely, we can talk about how you can discuss this with your parents.
Oh, it sounds a little scary.
Well, getting tested is the right thing to do, and it's a treatable disease. For now, we want to ensure that you have a safe pregnancy and a healthy baby.
All right, thank you.
So I think that this is exactly how an interview should happen in terms of identifying an opportunity, how to talk to the patient, how to engage them in hepatitis B screening. Again, by someone like this, okay, you're identifying if she has hepatitis B and how you can treat it, but also she's about to give birth to a kid. So again, you're going to prevent the vertical transmission, you're going to stop the spread of hepatitis B from mother to child. Okay, so it actually gives a perfect platform, especially for those who are in primary care, those who are in family practice, to identify these individuals. And let's say she turns out to be negative for hepatitis B. This is a unique opportunity for her to get hepatitis B vaccination and also endorse it to the newborn, since it's the universal vaccination recommendation. Okay. So I think in the interest of time, we are actually 10 minutes early, but this is good. We really appreciate the interest that you all have. If you want to discuss any cases that you have in your practice, please feel free to talk about it.
Yeah, any cases or any questions that you might have on this first module. And again, we're going to go deeper into the serology sections in the next couple classes. Feel free to type it in the chat too.
Yeah, so we don't want this to be a purely didactic or a purely PowerPoint kind of presentation. We want this to be as interactive as possible. Again, if you want less slides and if you want me to actually pick up cases that I have, these are all real world cases that I have to, that I can discuss, we can open up that kind of platform. Let us know which way you feel better in understanding about hepatitis B. And again, this is about education. You or I, we're all going to learn from each other.
Yeah, Raman, it looks like we have one question in the chat. Can the transmission be passed down to future generations?
Absolutely, yeah. So in patients who have hepatitis B, so we're going to talk more about in the serology section. So E antigen positive mothers, the transmission rates are almost as high as 90%. Now, in E antigen positive mothers, we do recommend that the child should get hepatitis B immunoglobulin and hepatitis B vaccination right after birth. So a lot of the time we can actually prevent a vertical transmission, but we can curtail it from a 90% to almost 15%. How we can reduce it further is by treating the mother for hepatitis B. So again, we typically want to treat the mother with antivirals in her second or third trimester. So if we bring down that viral load, the transmission rates will be much, much less. With E antigen negative disease, the transmission after the universal vaccination to the kid is practically negligible. So E antigen mothers typically do not pass it on to the babies unless, the mothers have very high viral load. Again, which brings to the question of treating the mother and also vaccinating and giving immunoglobulin to the baby.
Any other questions? No. Would anyone like to volunteer for a case for next week? Or I'll be volunteering Ram to do it.
Actually, we have a question. It was sent over to me in a private message. Sometimes these messages can get a little bit hinky, so I'm going to post this over to the Everyone channel for you.
Okay. So the question looks like, regarding babies born to positive hepatitis B mothers, we do post-vaccination serology testing at 9 months of age, and we drop monitoring them. Should we continue monitoring these children? How soon post-vaccination, and for how long? So this is a great question. So patients who are born to positive mothers, we have to remember two things. We have to give them hepatitis B immunoglobulin, and we need to do hepatitis B vaccination series. So this is 0, 1, and 6 months. And the newborn should undergo all 3 vaccinations. Then we're going to test for hepatitis B surface antibody, and if they test positive for surface antibody, those are the individuals who are protected. Remember, about 10% or so may not mount a surface antibody. If they don't mount a surface antibody, those newborns are still at risk for developing horizontal transmission of hepatitis B, either through close contacts, mother or close contacts in the household. So again, these babies should be monitored, and we should recommend revaccinating them using a similar dosing schedule or double the dose of hepatitis B vaccination. And we should certainly see that that particular baby gets protected titers. Okay. Once you have a protected titer, that baby is protected. And I think, again, another test probably in a year's time is good enough until the baby becomes an adult.